You're listening to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is May 18, 2012, and I'm your host, Dr. Jay Portnoy. Our topic today, non-IgE-mediated reactions. Our presenter is Dr. Nikita Raje. She's an allergy immunology fellow at Children's Mercy Hospitals and Clinics. Welcome to Conferences Online Allergy from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. Today is May 18, 2012, and this is a CME accredited conference, meaning that if you go online and view this and fill out the information on our website, you can be granted 1 hour of free CME. You may need to make sure that you participate in the conference in order to do that. Our presenter today is Dr. Nikita Raje. Dr. Raje is a almost second year allergy immunology fellow here at Children's Mercy Hospitals and Clinics, and she's agreed to speak with us today about non-IgE mediated reactions. So thank you for coming today, Dr. Raje. Here's the keyboard and the mouse. Let's try it. See what? She didn't have much choice. You didn't have much choice. Okay. Sure you did. You didn't have to.
Dr. Daly, I will not do that.
We really appreciate your willing to do that.
Well, I should say I'm happy to be here. So here's my presentation on non-IgE mediated reactions. No disclosures. The objectives of this talk are to explain the types of adverse reactions of radiocontrast media and the risk factors for the reactions, describe the appropriate pre-medication protocols to prevent the anaphylactoid reactions to radiocontrast media on re-exposure, to describe the types of adverse reactions with local anesthetics, the diagnostic tests used, and their management, and to describe the types of adverse reactions with opioid medications. So here's the pretest. The diagnostic testing for a reaction to radiocontrast media may include skin test, blood test for specific IgE, patch test, and testing is not recommended. The best pre-medication regimen for prevention in persons with a history of a previous anaphylactoid reaction would be cimetidine, ephedrine, and prednisone, diphenhydramine and prednisone, montelukast, hydroxyzine, and prednisone, or IV methylprednisone and IV cimetidine. And the third question, the pathophysiology of non-IgE mediated reactions to local anesthetic use could be secondary to complement activation, direct mast cell activation, vasovagal syncope, psychoneurogenic, both C and D. So I'll be using non-IgE mediated, pseudoallergic, anaphylactoid, all these terms interchangeably. They all mean the same thing. So let's start with symptoms of the pseudoallergic reactions, and these are common to all the drugs that can cause pseudoallergic reactions. So respiratory symptoms, sneezing, coughing, asthma episode, meaning wheezing, bronchospasm, choking, rhinitis, tachypnea, stridor, laryngeal edema. GI symptoms like vomiting, nausea, abdominal pain, and diarrhea. Cardiovascular causing angioedema, hypertension, angina pectoris, ventricular tachycardia, arrhythmias, other arrhythmias, cardiac arrest, hypotension. Neuromuscular symptoms like chills, confusion, muscle pain, and loss of consciousness. Skin and mucosa, rash, cyanosis, dermatitis, erythema, flushing, pruritus, skin eruptions, urticaria, conjunctivitis, and severe adverse reactions like anaphylactic shock and death. So here are the pathways which are thought to be playing a role in the pseudoallergic reactions. And as you see, here's where the IgE-mediated reactions would start, where it would cause a transduction through several pathways and cause a release of histamine and tryptase-like products, also some cytokines and chemokines, or arachidonic acid end products like prostaglandins and leukotrienes. Instead of that, the non-IgE mediated reactions are caused by compounds like mastoperin, that's the product in the venom, insect sting venom, substance P, and other neuropeptides, and compounds like 4880, those are the products product that is formed from formaldehyde. And these products cause activation through G protein, and then there is transduction through other signaling pathways, leading to the mast cell degranulation, causing the release of the same products that can be produced by IgE-mediated reactions. Similarly, there are other drugs which, like radiocontrast media, liposomal drugs, or what is called chromophore EL, which is a substance used as a vehicle for some drugs like Taxol. And all these substances can activate the complement pathway, and through that they'll cause a similar reaction, mast cell degranulation and production of similar end products. Opioids like morphine can activate opioid receptors on mast cells and cause direct mast cell activation. And NSAIDs can cause inhibition of COX-1 and lead to increase in the leukotrienes and decrease in the prostaglandins, and end up with similar results. So these are the different kinds of pathways. So as I mentioned, the direct mast cell activation is caused by opioid drugs. They activate the opioid receptors, use phospholipid C transduction mechanism. The compounds like Hymenoptera venom, the product is called mastoperin. Compound 4880 and neuropeptides can act via G protein. And then also I didn't mention that calcium ionophores, this is the specific one mentioned, A23187, can increase the cytosolic calcium ions, and that can lead to mast cell degranulation too. Complement activation, it can occur via classical, alternative, or mannose binding protein pathway, and it is caused by radiocontrast media, liposomes, which are used for targeted or controlled release of the drugs, or adjuvant solvent systems like chromophore EL, which is used in Taxol and some other drugs too. And as I mentioned, the NSAIDs act via inhibition of COX enzymes. So let's start with the radiocontrast media. So these are the types of radiocontrast media. They are classified as ionic and non-ionic, and each of them can be monomeric and dimeric, and further classified according to their osmolality. So the hyperosmolar are more than 1400 milliosmoles per kilogram. Low osmolarity is somewhere between 600 to 900, and then isoosmolar are very low, similar to your plasma, so 290 milliosmoles per kilogram. And these are the specific ones here. So the types of reactions that can be caused by radiocontrast media are chemotoxic reactions and hypersensitivity reactions. So the chemotoxic reactions, they are related to the chemical properties, so the ionicity, dimeric or monomeric, or the osmolality. They are dependent on the dose, the concentration, and the infusion rate. They manifest as cardiotoxicity, neurotoxicity, or nephrotoxicity. They can also be vasovagal seizures. They can give seizures, arrhythmias, and just slowing the infusion rate is sufficient to avoid the further symptoms. On the other hand, the hypersensitivity reactions are idiosyncratic, independent of the dose and infusion rate, and the types are either immediate or delayed hypersensitivity reactions. The immediate hypersensitivity reactions occur within 1 hour of administration, and the delayed can occur anywhere from 1 hour to several days after the administration. And the delayed ones are usually manifested as exanthems or as fixed drug eruptions, erythema multiforme. They can also go on to develop Stevens-Johnson's or TEN, vasculitis, urticaria, and angina. So the pathophysiology, the IgE-mediated reactions are very rare, but they are still possible. Non-IgE-mediated reactions are more common, and the mechanisms proposed for radiocontrast media are basically they can cause direct mast cell activation, they can activate the coagulation, kinase, and complement pathways. They can inhibit the platelet aggregation with increased serotonin release, causing similar reaction, inhibition of enzymes like cholinesterases. So a lot of mechanisms have been proposed, but they are all controversial because it's seen that these mechanisms occur in the cells of the patients with the immediate hypersensitivity reactions, but they also occur in the controls who have tolerated the radiocontrast media. Epidemiology, overall incidence of radiocontrast media reactions is 4 to 12% with ionic media and 1 to 3% with non-ionic. Life-threatening reactions are again rare, 0.2% for ionic and 0.04% for non-ionic. And death has occurred with both ionic and non-ionic, but rare again, 1 to 3 out of 100,000. When you consider ionic high osmolality contrast media, the incidence of the reactions is a little higher, so 5 to 13%, and non-ionic low osmolality is the lowest, so 0.2 to 3%. Again, the life-threatening reactions, depending on the osmolality, it goes down further if it's non-ionic, and it's a little higher in high osmolality. So the risk factors for developing the reactions from radiocontrast media: female gender, age 20 to 50 years, history of previous radiocontrast media adverse reaction, history of atopy, history of asthma. However, the history of asthma is the evidence is there is no specific evidence whether it's just increased incidence of the reactions or whether it's more severe reactions when they occur. Other possible risk factors are some medications that if patients are on beta blockers, aspirin, NSAIDs, or interleukin-2. There is this misconception about shellfish and seafood allergy being a risk factor for radiocontrast media, but as I mentioned, it's a misconception. The seafood allergy is not an independent risk factor. The association started because of this high iodine content for both shellfish and radiocontrast media, but these molecules were found to be too small to cause an anaphylactic reaction. And the shellfish allergy is found to be caused by tropomyosin protein, which is not related anywhere to the radiocontrast media. Also, there is this misconception of contact dermatitis if someone has contact dermatitis from povidone iodine, it is a risk factor for radiocontrast media, but again, that hasn't been proved and it's not related.
If you think about it, salt is iodized, so we're eating it all the time, so it doesn't have anything to do with it.
So, for the diagnosis of the radiocontrast media reactions, consider the differential diagnosis like vasovagal reaction and chemotoxic reactions. For vasovagal, the differential point is it causes bradycardia with hypertension, where the other anaphylactic reactions could have tachycardia, not exclusively, but something to keep in mind. Testing is not actually routinely performed. The tests that have been done so far for research purposes and clinically are a tryptase level, which is drawn between 30 minutes to 3 hours. Histamine and its metabolites have been seen, but they don't really help with the diagnosis. Skin prick test, it is best to be performed between 2 and 6 months after the reaction, as the incidence of having a positive skin prick test is lower if it's performed before or after this period. So at this time, testing is only suggested for patients who have had a reaction within the past year and would require future radiocontrast media studies. So it is not routinely performed. The tests that have been suggested are intradermal tests, and it has shown to have low false positive or irritant reactions. Skin prick test is not sufficiently sensitive by itself, but is performed prior to the intradermal test because of some rare extremely sensitive patients who could have systemic reaction with intradermal testing. So there are a couple of studies that I looked through. This was a study, anaphylaxis to iodinated contrast materials, performed in 2008. They looked at 96 patients who had hypersensitivity reactions to radiocontrast media. They did intradermal testing with the culprit radiocontrast media as well as 4 other common agents, and they did this to see if the specific media caused the reaction. They wanted to look for alternatives. For 71%, the intradermal test was performed within a year of reaction, and they found 4 patients who had positive ID tests, and all 4 of them were at least reactive to that specific agent which they received and had the reaction to, apart from the others, like the other 4 that they were tested for. They then, after the intradermal test, they had this basophil activation test done, and all 4 had, for all 4 of them, it matched the skin test, so it was positive. So 2 of them had negative radiocontrast challenge to the agents that had tested negative, so they were challenged for something that they tested negative for. And one of the 2 who also had that radiocontrast media that they tested positive for, again, which I don't know why they would have given it to that patient since he tested positive, but he received it, and that patient did have hypersensitivity reactions again. So,
only 4 out of 96 patients that they tested
right.
with the intradermal showed anything of value. This wasn't done with the control population either, so you don't know what the incidence of just having a positive ID to that would be with anybody.
Right.
So,
yeah, this wasn't. The next study was actually done with controls. So here, this was in 2009. They looked at 122 patients with hypersensitivity reactions. They looked at 71 unexposed controls, and they also looked at 11 exposed controls who had the radiocontrast media but did not have a reaction. And for this study, 26% of the patients did have a positive ID, and then out of the 11 exposed controls, none of them did, and 3 of the 71 unexposed had positive ID test. 50% of the patients who were tested within 2 to 6 months had a positive reaction. So even in that period, it was only 50%. However, it was better than like 18% of the positive reactions if they were done before or after not between 2 and 6 months of the reaction. 86% of these patients had a positive ID test to the specific radiocontrast media that they had received, suggesting that at least it is sensitive. So the intradermal test was found to be a little more sensitive. But the optimal concentration for the intradermal test is not yet determined, and up-to-date actually suggests testing with 1:100 or 1:10 and then undiluted radiocontrast media. However, with undiluted, there could be a chance of false positive testing. There was another study that was mentioned with just 29 patients, but the negative predictive value was considered to be more than 90%. So that's for the diagnosis.
Because we don't, I mean, I've never done skin testing for radiochemistry.
Right.
I don't know if you have DFJ, but.
No. Is that just to the newer agents, or to the old agents? It was never something we did.
Now they are just using the low osmolality. So they have, now these studies have shown, again, I think we saw an abstract in the college meeting where they had done some testing, but there is no validity because
what's the mechanism? I mean, is it really an IgE, or is it just stimulating the G protein like you said, and this is getting at that kind of reaction?
So as I mentioned, the mechanisms have been proposed, but none have been confirmed, and the skin test actually up to date suggests that even when the skin test is positive, that would mean that basically the exposure has caused degranulation and is giving a immediate reaction, but that doesn't really mean that it's IgE-mediated.
No,
but,
it doesn't.
Right. So.
But those people then when they get their procedure, do they have anaphylaxis?
The reactions are similar to an anaphylaxis. So even with pseudoallergy, sorry, I'm going back. These are the symptoms. So they can still have like very severe reactions. So even if it's not IgE-mediated, some mechanism causes the degranulation of mast cells. It's going to give you a severe reaction and cause.
The skin test is predictive of them having that reaction.
Yes. Like intradermal test has been found to be.
Because we don't do it. Maybe we should.
What happens with change management? If I need another test, you'd say, well, can you use a different agent that's from a different class of osmolality?
But that's implying that there's like immunologic cross-reactivity, and it may be that somebody who just has a tendency to release mediators from their mast cells is going to do it regardless. I mean, is there a lot of cross-reactivity among these different agents in terms of if somebody reacts to one, are they likely to react to another?
I thought it had. I've always thought it had to do more with the osmolality.
Right. And anyway, you're going to pre-med them. I mean, right? I mean, that's the next thing you're going to
For the next, yeah.
Well, if you can identify an agent that you don't react to, you don't need to.
So it's not a different class that they suggest using. It's as low osmolarity as you can go. Right. What is available. So but not everywhere.
So the recommendations are to use lower osmolality and pre-med them.
So if I skin test them to these 4 agents, because you showed 4 different agents with different ionic and osmolalities, I mean, what's the concordance of skin test reactivity among them? If you test to all 4, I mean, if somebody reacts to one but not to another, is giving the other a safe alternative, or is that really predicted? Or
so this study
did any of these studies really?
This study looked at 13 different radiocontrast media when they tested. And they looked at basically high osmolarity, low osmolarity, isoosmol, all of those. But pretty much all the studies showed that non-ionic had lower rate compared to high osmolarity. But they didn't specifically say, and isoosmolar had lower than the non-ionic, low osmolar.
So but what about the correlation among the different agents within an individual patient?
A specific patient, like one patient, whether they're higher.
I'm just looking at the correlation among them. So if you react to one, are you likely to also react to the other? Maybe that people are reacting to this one and to that one, but maybe it's different people reacting to each one. And
right.
How well did they actually correlate with each other? That's the question.
Right.
Nikki, on this thing, I'm confused. You had 122 patients, and they got a history reaction. They got ID tested. Is it 26% that reacted?
That had a positive ID among the ones that had the hypersensitivity, but among the controls.
26% have the 122.
Right.
Yeah.
So
okay, but what's the 86% of the positive IDs? So that's 86% of those 26%.
No. So the 86% is to the specific radiocontrast media that they had. So they tested for lot of other radiocontrast media for all these patients. So some of the ones that were positive for some other radiocontrast media and not for the radiocontrast media that they had reacted to.
But it's 86% of the 26%.
Of the ones, right.
So it's kind of confusing because when you look at it, 86% had positive IDs. You're thinking, well, 86% of these 100.2. It's really 86% of 26%.
We really want to know the negative predictive value. So if you predict something and they're negative, what's the likelihood they're actually going to have a reaction?
Which we don't know.
I thought the other study had something about negative.
Yeah, but that study wasn't, I couldn't find that study. So this is just up to date saying that there was this one specific study which showed negative predictive value. So it's proposed to be high, but we don't know exactly.
I also find it intriguing that they react right after the reaction, but not before
or after.
I mean, is there something about having a reaction that sensitizes them? But when they got but they would have been negative had you tested them before they had the test done that caused the reaction. So it's not as predictive because they're only reacting after the fact. So it's not helpful to test somebody after they've reacted. You want to know before they react if they're going to react. And in this case, their likelihood of reacting was much lower, so it's not as helpful.
Well, the other
thing before the 2 months, or before they actually, see, I interpret that to be the 2 months.
Does that mean that there's like a refractory period?
Yeah, so they had the reaction, and
they used all their
first 2 months.
They used up whatever they
Exactly.
all the
Presumably,
Before they actually have the
then they
reaction.
might, though, right? Because, I mean, if you're saying that skin test is positive, then they might actually do granulate for that small amount, even if, because it's not a memory thing, it's not like an IgE being built up to it.
We
It's
don't
that
really
they get
know
your
about it.
granulation.
Maybe the
No, I just think that
have the
would be
reaction
interesting to
makes
look
you more
at.
likely to have a reaction.
Yeah, but it might be interesting as a predictive thing because of that, because it's not IgE mediated. You're not needing to be exposed to build, create the antibody. You're just granulating the mast cells.
Wow. These studies always get confusing.
It would be interesting just to take controls, just like anyone who's getting a radiocontrast thing, do the prick beforehand,
See what happens.
and then see if it correlates.
I think we should do
The
that.
prick,
Yeah.
that would be easy. You could just enroll anyone who's getting a contrast.
Right.
And then you could see, okay, they have a positive test, but they actually reacted. They positive.
And
Probably you would just find a lot of false positives and a lot of people
Right.
will react.
But you also could correlate that. You could also correlate with the risk factors. Those same patients. So if they had a positive, how many of those risk factors did you put? A female, they're between 20 and 50 or whatever. All that stuff, it's very topic. All that stuff.
Right.
You could correlate to see.
Right. But that would be like because that was an interesting article where I could,
You do it to
the whole article. But it does.
Correlate what they get.
The study that they did, the controls and all, they have described everything. It's a lot of information you could look at. So.
Okay, continue.
There's your fellows research part for next year. You can live over at Truman.
Yeah.
You can do another research project one each year.
But they'd actually have to get the procedure with each of the products to see which one for each one.
Or you could just test them to all just to see, like you're saying, what the cross-reactivity is, and then make sure that you're testing them for the one that they're about to get, and then just see what.
Dr. Raje can do.
All right. So primary prevention. So routine use of low osmolarity contrast media has obviated the need for pre-medication for patients with risk factors. However, if the low osmolarity contrast media is not used routinely at some specific facility, consider the non-ionic and isoosmolar low osmolarity contrast media for patients with these factors. So asthma using beta blocker NSAIDs or IL-2, previous radiocontrast media reaction, patient receiving contrast via power injector, and maybe just mean that they are going to have like really fast infusion. There's no infusion. Basically, it just goes in.
Why would a hospital not use the safest product? I mean, if they're going to use this product that's known to be
Hopefully they are all using low osmolarity by now.
But you're saying if somebody doesn't routinely do that,
right, because
they're
there
using
might be facility, like, smaller facilities.
Well, as a patient,
somewhere.
would I be informed that this hospital is using a less safe product so I might choose to go to a different hospital? Because I think I would want to know that.
Right, sure.
It's probably procedure dependent too, because when I had my studies, they said, well, we're going to use this dye or this contrast because this is the one that seems to give us the best results or something. And it had little to do with the reaction. I've had a reaction to radiocontrast media.
Oh, okay. You did?
Yeah. I broke out an eyes out at Nopalin Park at one of the centers out there. And they didn't know what to do. So I was going around asking for Benadryl. And
You're treating your own.
Yeah, I did.
Or if they just have anxiety or patient request, they should be using it.
That's why I gave a talk on radiocontrast to the radiology residents here in Truman a couple of years ago after that happened.
Continue.
So one of the several pre-medication regimens proposed is prednisone 50 milligrams given 13 hours prior, 7 hours prior, and then 1 hour prior to the procedure, along with diphenhydramine 50 milligrams PO or IV just 1 hour prior to the procedure. Along with those, yes, low osmolarity contrast media or isoosmolar agents should be used, and there are some gadolinium-based agents that can be used too, which are used routinely for MRIs. And then emergency medication should be administered for patients. Some other regimens, so 2 doses of glucocorticoids were better compared to 1 dose of glucocorticoids. Some people propose use of H2 antagonist along with H1 antagonist. With the combination of H1 antagonist and glucocorticoid, but it did not reduce the number of radiocontrast media reactions. There was this one study with 627 procedures that showed that the incidence of repeat radiocontrast media reaction reduced from historical 17 to 60% to 9% with a combination of H1 antagonist and glucocorticoid, and then further reduced to 3.1% with addition of ephedrine. But this was an older study in 1980s. Ephedrine is no longer used with.
It's not available. You can't get it.
Right. So if someone has an emergency procedure planned, this is the proposed pre-treatment. So give hydrocortisone 200 milligram IV immediately, and then every 4 hours till the completion of the procedure. Along with that, diphenhydramine 50 milligrams 1 hour prior to the procedure, and then again use the lowest osmolarity possible and emergency treatment available. So if someone has a reaction, stop the infusion, ABCs, and treat the anaphylaxis as any other anaphylaxis. So give epinephrine, supine position, oxygen, antihistaminics, IV fluids, and then steroids plus minus if there is a persistence of symptoms. If it's a milder reaction, just having antihistaminics may help. So that's about it for the radiocontrast media.
And again, it's rate dependent and dose dependent.
Yes. So yes.
Hydrocortisone 200 every now and then every
4 hours.
Long procedure.
Right.
That's a long procedure, 4 hours?
Well, sometimes they can, most of the times, CAT scan is so easily available. Now there wouldn't be a second dose at all because by that time the CAT scan will
I
be
guess
done.
if you're having an operation where periodically they have to check some flow through something and they're giving you small amounts.
It's not for the procedure 4 hours. It's like if someone's planning a surgery, before the surgery, they want to have a CAT scan of the abdomen or something. Then by the time they get it, they give the hydrocortisone till the CAT scan is done. So.
Okay.
So switching gears here, local anesthetic medications. So these are the categories of the local anesthetics used, ester group and the amide group. So benzocaine, chlorprocaine, cocaine, procaine, these are some of the esters and the amides. The most common ones are lidocaine and prilocaine, ropivacaine, like the other ones. So these are the two groups of local anesthetics. So the adverse reactions are of several types. Type 1 allergy, that is IgE-mediated. It's rare and it can cause urticaria, angioedema, bronchospasm, and full-blown anaphylaxis. Type 4 reaction is contact allergy, and it can be local contact allergy or a systemic allergy, systemic contact allergy. The reactions could actually be hypersensitivity to other ingredients that are added, so like preservatives or latex from the bottle that's used can cause a problem. The other ones are what we are talking about, pseudoallergic or non-immune anaphylaxis. And the mechanism proposed is psychoneurogenic or vasovagal or autonomic. Local anesthetics can also have a toxicity reaction that would give cardiovascular or CNS reactions. And again, pharmacological effect of other ingredients like adrenaline, epinephrine can cause reactions. So the pathophysiology of non-IgE mediated reactions. So the psychoneurogenic reactions, they are thought to be from the direct action of on the nerve, eliciting a reflex cascade via CNS. And it can cause hyperventilation, paresthesias in the fingers or perioral area, dizziness, palpitations, tachycardia, nausea, and just not feeling well. And this is completely different from radiocontrast media where there's direct mast cell degranulation and complement or kinase pathways that play a role. The other non-IgE mediated reactions can be just a vasovagal syncope, which would give bradycardia and pallor compared to flushing and tachycardia with other reactions. Systemic toxic effects, these can actually occur at therapeutic levels too, though it's like a toxic level, but in a highly sensitive patient, it can be at therapeutic levels. And it would give anxiety, tremulousness, excitement, seizures. It can also cause vasomotor collapse, hypotension, apnea, stupor, myocardial dysfunction. Sympathetic stimulation can be from endogenous catecholamines in response to pain, or due to the epinephrine that was added to the local anesthetic solution. And it would give tachycardia, hypertension, anxiety, palpitations. So for the diagnosis, history is very important. What was used, what was the preservative, any additives that were added to the solution, what was the reaction that they had, when was the reaction, how long after, what were the symptoms. So history is very important for the diagnosis. And then the next thing is to do a skin test and a challenge. So when would you do it? Symptoms that could suggest IgE or non-IgE mediated, you go ahead and do the skin test. What do you test for? So sometimes patients come in saying it was like 10 years ago and now I'm having a procedure. I don't know what was used at that time. So in those cases, test the alternative local anesthetic from another. If you know it, do it with another group. And if the culprit is actually an amide, like lidocaine, so you can use another amide also. But if it's not known, just test with lidocaine. Why lidocaine? Because it's commonly available, and there have been cases where if someone had a reaction from lidocaine, they didn't end up having another reaction. So lidocaine is a safer alternative. So for the testing, use the preparation without vasoconstrictors, but you can use the preparation that has preservatives like paraben. But if the test ends up being positive, then you would have to consider paraben sensitivity and retest with preservative-free preparations. So the procedure.
I don't know where you get those or how easy it is, because the stuff that
it would need, like, you would have to call the patient because it's not as readily available. So you either have to wait or call them.
I don't know where you get them, maybe through the pharmacy or something, because the ones that we've gotten usually they all have paraben.
And that's the reason for just doing it with paraben-containing ones. And then if there is a positive test,
I suppose you can then test them with paraben to see if they react to that.
Can you get
that?
Well, the studies that I read on it, like they had to dilute their, and there's no like protocol for like how you make it, because we had that patient that we thought had paraben in the lidocaine. So it's not, people have done it in studies, but there's no like protocol of like getting it and at what dilution you would do.
So the procedure is skin test, skin prick test, and with the full strength, and then followed by intradermal testing using 1:100 dilution to avoid false positive results. If both of them are negative, and false negative rate is very low, less than 1%, but if they are negative, then subcutaneous provocation test with 20 minutes between each step is proposed. So the subcutaneous challenge, there's this article which suggests that we should be doing a placebo step, just because there is this psychoneurogenic reflex that can be playing a role. I think placebo step is important. So single blind placebo step to be considered if it's strongly suspected that it's anxiety related, and then use 0.1 ml of undiluted subcutaneous challenge followed by 0.5 ml and then 1 ml. Actually, the authors of this article suggest that if placebo step is positive, people can just stop there, but they do suggest that reverse placebo provocation can be performed. So somewhere the patients are informed that this will be blind, and they will be told about what was used at the end of the challenge. So somewhere they add a step where they give the local anesthetic, but tell the patient that it's placebo, and see if they react to it. So that way, if the placebo was positive, they tell, okay, this was just a placebo, and it would basically cause frustration on part of the patient. So they suggest doing it with reverse placebo, and if at that time the local anesthetic works and it doesn't cause a problem, go ahead and explain it to patient. Be respectful, just because it can be kind of, they would feel that they are fooled or something, but finally end up telling them that you didn't react. So, and this happens, and this is common because there is this concern about psychoneurogenic reflex. So that's what the authors suggest. So once the test is done and the information about the specific local anesthetic that was used for the challenge, the vasoconstrictor or preservative that was used or stabilizer content of that specific challenge solution, and the total dose used and tolerated should be conveyed to the referring physician, because that's where they are going to use. And the total dose is important because that way they can restrict it to that level, and it would be important for the toxic effects that we were talking about. So non-IgE mediated psychomotor sympathetic reaction, for those reactions, just reassure, you can just use empirically use just a different local anesthetic and of use. For toxic effects, as I said, cumulative dose can be kept as low as possible. So just a little bit about opioid medications. So the types of reactions with opioids are side effects with no immune mechanism, so nausea, vomiting, constipation, sedation, respiratory, depression. Non-IgE mediated pseudoallergic reactions are pruritus, urticaria, bronchospasm, hypotension. These are self-limited. They do not need discontinuation of the medications, and they are related to the direct mast cell activation and degranulation. But they are milder reactions compared to the severe reactions from IgE-mediated. Type 4 hypersensitivity reactions have been seen, and it's mainly dermatitis, and then patch test is useful in those cases. Type 1 anaphylactic reactions are rare. Symptoms are actually similar to non-IgE-mediated. Pruritus, urticaria, angioedema, hypotension, urinary retention may be observed, but they are severe enough where you wouldn't repeat the same opioid, but use another alternative one. So for the management of these reactions, if it's severe, treat it like any anaphylactic reaction with epinephrine and antihistaminics. Milder reactions, just antihistaminics. They propose using alternative opioid medications and considering class switch. Specifically, methadone and fentanyl are considered to cause less itching. So these are the classes where different classes where morphine, codeine, hydrocodone, all of those are in one class. The meperidine, fentanyl are phenylpiperidines, and diphenylheptanes are methadone and propoxyphene. I guess that's the end of my presentation. So the diagnostic testing for a reaction may include, sorry, a bad question, not me, I realize not may included, but should be, like the most commonly testing is not recommended, so sorry about that.
But you could do a skin test.
Yeah, I was like, right, talking about
so it's not me, yeah. This is from that presentation.
The other thing is that you talked in the thing about the radio contrast media about delayed reactions. I think you and Dr. Miller had a patient that had like a delayed reaction.
Yes.
At the college or the academy, someone had a poster in the last couple of years where they did some patch tests. And I think actually someone also did like lymphocyte transformation, like looking for, like a type 4 reaction.
And there is this one, I think it's the same study where when they did the intradermal test, they actually looked at the results 20 minutes later, and then they looked at the intradermal test site on one day, like so 24 hours, 48 hours, and some studies 72 hours. So they look and they did the patch test. So yes, that study does propose patch test and intradermal test with like looking at it later for the delayed.
And I think when David Kahn gave his talk last summer, we talked about for some of these type 4 reactions that some places were trying to do patch testing for that, but that there was some data that showed that doing an intradermal and looking at it at 48, 72 hours may be more effective than the patch.
So some of them did a combination, so do both kind of, but yeah, that might be the alternative for that. So yeah, so the next question, best pre-medication, yeah, and then the pathophysiology of non-IgE mediated reactions to local anesthetic is E, because it can be vasovagal or psychomotor.
So in terms of the local anesthetic allergy. That always comes up. Is that real? We ask this question every time we talk about it, but have you ever seen a patient have a true reaction to it?
Has there ever been a case report, has anyone ever been aware of like someone who had a serious or severe and life-threatening type of reaction from a local anesthetic?
Okay. Well, we've had people here, and I had a patient when I was in Alabama. In Alabama, I had a whole bunch of middle-aged women who came in with local anesthetic reactions. Only one of them, I mean, I must have, in that year, I must have done like 30 of these tests or something. And there was one woman who had a positive, had a nice wheel and flare. We had one of our former fellows here who never believed there was such a thing, and he was in practice in Texas and was there maybe in his first month of practice. He tested this woman and said, well, I don't expect anything positive. And she had this huge welt, sort of thing. And he told me about it. He called me up when it happened to tell me that he actually saw something, So, I mean, there's probably some people
Did you challenge that lady then to see if she really was allergic, or
because she had such a large wheel and flare on the skin test.
But you see, that's the problem. We don't know what the false positive rate is. The same thing with the penicillin test when Sullivan did all that stuff. If somebody had a positive test, they never challenged them, so we don't know what the false positive rate is.
Yeah.
I don't understand, like, if you're diluting it out to avoid false positives, like when you do the intradermal, when you're actually injecting the local anesthetic, you're using the unconcentrated full dose. So if they have a high from that, like, how can you call that false positive on that?
Is it an irritant reaction?
That's how you're administering the drug normally.
But that for local anesthetic, that's the reason they propose that it has to be followed by subcutaneous challenge. That's undiluted. So, and that's in series. So they do 0.1 ml of undiluted, then 0.5, and then 1
ml. You're saying if the undiluted is negative, but the challenge is positive, then it's considered an irritant?
No.
Well, it depends on what you mean by positive. If positive would only be positive if it's systemic. If it's a local reaction, it wouldn't count.
So if the intradermal is negative, then like for amoxicillin, you would give it orally because that's how you would give like people would take amoxicillin. For local anesthetic, the way you would give it is subcutaneously when you really do it, right? Like they give like subcutaneous.
When you're doing your general procedure,
So that's what, like, you do challenge them after the test. So you just don't end up saying, oh, intradermal is negative, you can go home and get the anesthetic.
Yeah, we always do a graded challenge.
Always get the challenge, graded challenge.
And have you heard of people having systemic reactions from the local anesthetic that were actually, someone believed were actually IgE-mediated?
I don't know. The thing is, my experience, the ones that were positive, there were more middle-aged women, and a lot of these things seem to be more vasovagal or their reaction to the epinephrine, because they would do this whole thing about feeling jittery and all this other stuff. I can tell myself, when I had my dental procedures, there was one, I've told you this before, but they were drilling into my jaw or something, and they gave me 5 shots of epinephrine in one sitting. I mean, a shot of local anesthetic with epinephrine. And by that last one, I literally sat up. I was laying down. I sat up straight. I said, I'm going now. This is it. I did. I thought that was the end of the world. It was doing something to me. And I thought, my life was over. That was it, And I just thought I was going, And it was such a weird sensation. So I can imagine if someone, and we had a girl here that had gone to a dentist, got injected 5 times by the dentist with local anesthetic for epinephrine to remove a couple teeth that were rotted or abscessed or whatever. And he did it, and he did it in basically the same spot because there were a couple teeth together. And this girl, I believe he hit a nerve or some neurotoxic reaction because she went blind in the left eye on the side that he was doing this. She went blind, and she was over at KU for like 3 or 4 days in the hospital, and her sight came back. And so they were freaking out this was an allergic reaction. I said, I don't know how this would be an allergic reaction. She went blind, but I ended up having to do skin testing on her, We had to do this challenge and stuff because nobody would touch her because of this reaction.
But it wasn't a single blind.
It was only in one eye, right?
Yeah, single blind stuff.
But the thing is, I've seen, and I've had people that came in and they had these weird sensations that they felt nauseous or whatever. But I think a lot of this has to do with the amount that they give. Because it's more than, like, you go to the dentist, you think, well, I'll just get 1 shot and they'll fix my teeth. But sometimes these dentists are giving 4 or 5 shots all in one sitting. That's quite a bit of this medicine.
It really is. Yeah, I mean, you get jittery, there's all these weird reactions, and it's not an allergic reaction.
So it makes it harder to try to figure, because some of these reactions can seem like they're anaphylactic reactions, and then people have fear of needles, and then someone's jabbing you 5 times with a needle, and by the 5th time you're freaking out.
Yeah. Well, I think that the jury's not totally settled about this local anesthetic stuff, because if it was real, then there would be clear cases that would be in the literature that we'd say, yes, it's real. But even the experts who have seen large series are hard-pressed to come up with examples of true bona fide anaphylactic reactions to these things. So it's obviously very rare if it really happens. So we spend most of our time, like with food allergy, ruling it out rather than ruling it in. Comment about the opioids. We used to use codeine as our positive control on the skin test, so it really does cause a wheel and flare reaction, but it only causes degranulation of mast cells, not basophils. And so you can't use opioids to do basophil histamine release. And most of the time when you have systemic anaphylaxis, it's because the basophils that are circulating are releasing, having a few mast cells release their mediators isn't usually enough mediator to cause systemic anaphylaxis. You need to have those basophils taking part also, and you have IgE on those, so you get a good systemic anaphylactic reaction. The narcotics will cause you to have cutaneous, because that's where a lot of your mast cells are, and you'll get the hives and the itching and all of that stuff. But systemic anaphylaxis is pretty uncommon from opioids. I think it's for that reason.
Going back to local anesthetics, I don't remember this, but did you see anything where they ever looked at any of these patients and they tried doing basophil histamine release of any of those agents? Because I don't remember seeing anything about anybody trying and looking at basophil histamine release.
I was also wondering about checking a tryptase. Like if a dentist calls you, like, I have this patient in my office who had this reaction, like, can you prove that it wasn't allergic by sending a tryptase in that moment? Or at least,
but it's almost never a systemic reaction. It's because it's the patient's jaw swelled up, or they got hives right around there, or they felt weird, or something like that. But it's almost never an actual anaphylactic reaction. That's the history.
The other thing, Nikki mentioned it, but when I test for local anesthetics, I also test for latex. When I was training in the early 1990s, the dental school, just like here, we had the dental school right next door, and there were a lot of people, because that was in the age, when people started using gloves because of HIV risk, and there were a lot of people who were actually having reactions to latex, and that's what their reactions were, where they had the swelling, like Jay said, and it wasn't to the anesthetic. So we used to get these patients, and we actually found quite a number that were latex allergic, and it really wasn't the local anesthetic. So it may be something, especially if someone's had a lot of dental procedures, they don't use them so much. When back that time they were using dental dams and all this stuff all the time, that people were more exposed to that stuff.
Anyway, well, that was very interesting. These are clearly challenging.
Actually, there were a lot of other drugs which I could have talked on, but
yeah.
So said there was the hard to insulin, so a lot of pseudo allergies for other drugs. But
Brock, you've been very quiet. Do you have any final words for us before we close?
Final words?
Yeah. I think is this late?
I'll just repeat that if you might have a very sensitive test, but if you don't know anything about specificity, it doesn't mean anything at all. In other words, you could detect everybody with a test, and that's the problem with this. It's sort of without that information, it's kind of mumbo jumbo.
You have to take the people who have the positive test and challenge them to see if it's real. You don't do that, the test is completely worthless. It wasn't done with the penicillin, so we have no idea what the false positive rate for penicillin allergy is. Same is true for the local anesthetics and these other things. It's not helpful.
Well, the same is true of many of a lot of skin tests, Jay, with especially intradermals, because
I know.
You don't know what the clinical specificity is.
It's a big problem.
Yeah, you can't inhibit it with the same stuff that caused it. That's the biggest problem.
Yeah.
Yeah. Okay.
Well, thanks, Brock. All right.
Yeah.
Well, thank you.
Hey, congratulations on the seminar.
Okay.
Okay.
Right. Appreciate it. Anyway, we're going to stop there. Thank you, Dr. Raje, for an interesting conversation. This has been Conferences on Lyme Allergy from Children's Mercy Hospitals and Clinics in Kansas City. Have a great weekend, everyone, and we'll see you next time. Take care.
This has been an ACAAI production. To learn more about Conferences on Lyme Allergy or the American College of Allergy, Asthma, and Immunology, go to www.acaai.org. See you next time.